Good morning, and thank you for joining us today for our online forum, The State of Ohio's Health, the 2024 Health Value Dashboard. I'm Amy Rowling McGee. I'm the president of the Health Policy Institute of Ohio. The mission of our organization is to advance evidence-informed policies that improve health, achieve equity, and lead to sustainable healthcare spending here in Ohio. Thank you to our core funders who support HPIO's mission with their steadfast investment in our work. The following foundations have provided funding to HPIO throughout our entire 20-year history. These are the Health Path Foundation, Interact for Health, Mount Sinai Health Foundation, the George Gund Foundation, and the Sisters of Charity Foundations of Canton and Cleveland, and the Cleveland Foundation. Thank you also to the Health Action Council for support dedicated to the production of the Health Value Dashboard. The Ohio Center of Excellence for Behavioral Health Prevention and Promotion is the presenting sponsor of our educational event series. And here are all of our 2024 event series sponsors. We appreciate all of your support. For everyone who is participating in today's webinar, please feel free to type your questions in either the Q&A box or the chat box throughout our session. So you don't have to wait till the end of our presentation to put your question in. And we have several members of our team that will be monitoring the chat and Q&A. There are some questions that we could potentially respond to in the chat or Q&A, and then there's others that we might select to ask to our speakers. Created by and for Ohioans, the Health Value Dashboard is a go-to resource for many leaders in the public and private sectors who want Ohio to be a place where everyone can reach their full health potential. It's a tool for assessing Ohio's strengths and challenges, for setting priorities, aiding decision-making, and evaluating progress. With 112 metrics compiled from 77 unique data sources, creating the dashboard is definitely a team effort. I'd like to thank the staff of HPIO for their hard work on the 2024 dashboard, as well as our many advisory group members for their contributions as well. The slides and the resources from today's forum are available to download on the event page of our website. And I'd like to begin by introducing my colleagues, Becky Carroll and Carrie Almasy, who will present the key findings from the dashboard. Becky is the Director of Policy Research and Analysis here at HPIO, and Carrie is the Director of Assessment and Planning. Becky, we're looking forward to hearing what you have to say.
Thank you, Amy. I'm not sure why my picture is not showing up here. Just give me 1 minute, please.
If you need me to move the slides, Becky, I can do that. Are you not seeing the PowerPoint? Oh,
I can do the slides.
okay.
Okay. Well, I'll just get started. Well, good morning, everyone. Thank you again for joining us. We are very excited to be releasing our 6th edition of the Health Value Dashboard. You might be thinking, wait, didn't HPIO just release an edition of the dashboard last year? Why is there another one already? Well, we decided to switch to releasing the dashboard in even numbered years instead of odd numbered years. This would allow us to better align with the state budget development process. A quick thanks to Dr. Ani Ruhill of Ohio University. He has been helping us with dashboard data analysis since our 2017 edition. So why does HPIO develop the Health Value Dashboard? The US spends quite a bit more on healthcare than most other developed countries, and yet our outcomes are not better overall. For example, the US ranks near the very bottom on life expectancy when compared to other developed countries. So the idea of improving the value that we're receiving from our healthcare dollars was a common point of conversation at the time when HPIO created the first Health Value Dashboard. We also wanted some kind of roundup of data that would paint a comprehensive picture of health in Ohio. We worked with stakeholders from around the state to develop this framework. It encompasses the 7 domains in the dashboard. They are shown in the 5 white boxes on the left and the 2 intersecting circles on the right. The ultimate goal of the dashboard is to inform policy decisions. It does this through putting data in context, through rankings, trend, and disparities, providing concise, high-level findings, and making the case for evidence-informed strategies to address Ohio's greatest health challenges. So where do we rank? Ohio ranks 44th on health value in the 2024 edition. Health value is a composite measure of Ohio's performance on population health outcomes and healthcare spending. The health value rank is based on a state's performance on all of the metrics in those 2 domains, with both domains being weighted equally. After compiling 6 editions of the dashboard, it is clear that Ohioans continue to live less healthy lives and spend more on healthcare than people in most other states. Throughout the presentation and in the dashboard document, dark blue indicates the bottom quartile or the worst performing states, and light blue indicates the top quartile or the best performing states. This pie chart shows the modifiable factors that influence our health. It is based on research from the University of Wisconsin. It shows that 20% can be attributed to clinical care, 30% to our health behaviors, and 50% to our community conditions, or what we refer to as our social, economic, and physical environments. The slide also shows how Ohio ranks on the corresponding dashboard domains. Access to care has consistently been Ohio's best performing domain. However, as you can see, access to care is necessary but not sufficient for good health. These other drivers are also important, including everything from the quality of care we receive and the capacity of our local health departments, to the air we breathe, the food we eat, and how safe we feel walking in our communities. Ohio doesn't rank as well in these areas. Here's what it looks like all together. All the way on the left are those contributing factors for the systems and environments that influence health value. And in the middle are the domains that actually determine our health value rank. Some good news is that in this edition of the dashboard, Ohio saw more improvement than worsening on metrics. We improved on almost a quarter of the metrics and only worsened on 19%. Based on what we saw in the 2024 dashboard data, we identified 4 policy priorities to improve health value. They are mental well-being, tobacco and cannabis prevention, healthcare affordability, and creating opportunities to thrive. I will be briefly talking through the first 3, and then my colleague Carrie will cover the last one. First is mental well-being. The data shows us that many Ohioans of all ages are struggling with mental health challenges. The rate of depression among adults increased considerably between 2011 and 2022, with a quarter of adults reporting they had depression in 2022. Ohio ranks 41st on this metric, so very close to the bottom. There are also significant disparities in adult depression rates. For example, Ohioans with disabilities and Ohioans with low incomes experience especially high rates. Also concerning is that 1 out of every 4 Ohio adults who reported needing mental health treatment did not receive it. When looking at youth, in 2021, 43% of Ohio high school students reported consistently feeling sad or hopeless. Now, this by itself is troubling, but there are also some disturbing disparities here, especially by sex and LGBTQ+ status, with much higher rates among females, as well as gay, lesbian, and bisexual students, and students who reported other sexual identity or questioning. The dashboard includes 3 example policy recommendations to drive improvement for each of these priority policy areas. The 3 we selected for improving mental well-being are shown here. One is to improve access to telemental health services. This would include removing existing barriers for patients, such as gaps in insurance coverage and lack of broadband availability. We also recommend funding programs with evidence of mental health benefits, such as mental health first aid, and continuing to improve access to behavioral health crisis services, such as through the 988 Lifeline. Consistent with this recommendation, in Governor DeWine's State of the State address yesterday, he indicated a desire to expand mobile response and stabilization services, or MRSS, to every Ohio county. Through MRSS, a child or young adult who is experiencing significant behavioral health distress can receive assistance within 60 minutes. Our next policy priority is tobacco and cannabis prevention. Ohio's rates of tobacco use are higher than most other states. In 2021, 1 in 5 high school students reported using electronic vapor products. And these high rates continue later in life, as Ohio ranks near the bottom, 46th, on adult smoking. There is a strong correlation between smoking and health value, indicating that tobacco use is a leading driver of poor health and higher healthcare spending in our state. In 2021, 13.3% of Ohio high school students reported using cannabis. Although this is lower than many other states, it's going to be important for Ohio to keep an eye on this, given the recent legalization of recreational marijuana. Here are the 3 example policies to drive improvement on this issue. First is to establish a state-level tobacco retailer licensing and fund robust public health enforcement of the tobacco 21 age restrictions. Next is to implement restrictions on how tobacco and cannabis products can be marketed, and even prohibit products that are attractive to children and teens, such as those including flavors or that have packaging that look like candy. For example, in yesterday's State of the State address, we heard Governor DeWine express his desire for a statewide ban on flavored tobacco. And finally, policymakers will need to weigh important public health, public safety, and equity considerations as they create regulations surrounding the sale and purchasing of recreational cannabis. There are lots of lessons that can be learned from decades of tobacco regulation to inform these decisions, and we'll hear about some of those lessons a bit later in today's webinar. Our third policy priority is healthcare affordability. Largely due to state policy changes, the percentage of Ohioans without health insurance has decreased considerably since 2010, down to 7% in 2022. However, access to affordable healthcare still seems to be out of reach for many Ohioans. Nearly 1 in 5 live in families who spend more than 10% of their annual household income on healthcare. That's more than 2 million Ohioans with this high rate of out-of-pocket spending. From the dashboard, we also learned that Ohioans are more likely to seek care in emergency departments than people in most other states. And the emergency department is a very costly setting of care. Some ED visits can be prevented if affordable care can be accessed earlier in a lower intensity setting, such as a primary care office. Ohio ranks 45th out of the 49 states for which we have data on potentially avoidable ED visits among people with employer-sponsored health insurance. Just to give you a sense of the difference in cost here, the average cost of a moderate to severe ED visit in Ohio is $1,435 versus a range of $86 to $131 for a primary care visit. Here are our policies to drive improvement. First is to establish a healthcare cost study commission to identify key contributors to high healthcare spending, as well as ways to lower costs for consumers and employers. Indiana is an example of a state who has done this. Next is to ensure timely access to primary care, mental health, substance use disorder, and dental services by strengthening network accuracy and adequacy and increasing provider workforce capacity. Finally, we recommend monitoring the results of the new federal AHEAD model, which stands for All Payer Health Equity Approaches and Development. In this program, the federal government collaborates with selected states to improve health, achieve equity, and reduce healthcare cost growth. All right, I'm going to move over to Carrie.
Thank you, Becky. And thank you for being here today, everyone. My name is Carrie Almasy, and I am going to talk about one other key finding that was clear in this year's data. That not all communities in Ohio have access to the resources and experiences and environments that are needed to thrive. We found that many Ohioans, including Ohioans of color, with disabilities, with low incomes, with less education, those living in rural or Appalachian areas of the state, and members of the LGBTQ+ community continue to face barriers to health where they live, where they work, and where they play. Next slide. As Becky just shared, and I'm sure many of you are familiar with, these are what we often refer to as the social drivers or determinants of health. In the health value dashboard, they are represented in the social and economic environment, physical environment, and access to care domains. But these are really the community conditions like housing, transportation, education, and employment that affect our ability to be healthy and make healthy choices. Next slide. These conditions are shaped by a number of root causes, which include our culture, our values, and our beliefs, our institutions, and our policies and legislation. These root causes can either shape environments and conditions that support health, for example, by enabling civic participation and healthy activity, or they can inhibit health with factors like racism and discrimination that can limit opportunities for health. Next slide. Today, I'm going to walk through an example of how this all showed up in the dashboard in our data on the physical environment. Next slide. Ohio ranks 41st on outdoor air quality, which is worse than most other states. But when we dive deeper into the data, we find that Ohioans of color were more likely to experience that exposure to air pollutants than others. Underlying this data are those root causes that I just mentioned. Discriminatory policies and practices have shaped where Ohioans of color live and whether they have access to safe neighborhoods that are free from harmful conditions like pollution. Historically, practices like redlining have resulted in disinvestment, concentrated poverty, and depleted property values in neighborhoods where Ohioans of color lived. These areas then became vulnerable to highway and industry development, which resulted in greater exposure to air pollution, and those levels continue today. Next slide. I want to share an example of how this plays out through zoning policy. So on my screen, there is a land use map of the south side of Columbus. For those of you that may be unfamiliar, the south side is a rapidly changing but racially diverse area of the city. I want to point out two things on the map. First is the relative lack of green spaces and parks, which are represented by the green areas on the map. And second is the large areas of light, medium, and purple and dark purple. So all shades of purple, which represent industry and associated proximity to air pollutants. Next slide. We can contrast the south side with other Columbus area neighborhoods like Clintonville, whose land use map is displayed on this slide. Clintonville is a neighborhood with a majority of white residents. As you can see here, it has much more green space and has very little industry to speak of. Next slide. As I shared before, this is a very broad and complex issue in our state, and underlying factors like ableism and poverty shape which children can and cannot afford enough to eat. The data displayed here shows that children with disabilities, from families with low incomes, and from families with less education are more likely to be food insecure. All of this data and many other examples are included in the Health Value Dashboard's equity profiles, which begin on page 14 of the dashboard. Next slide, please. The bright lining in all of this is that we have the opportunity to improve those underlying factors through evidence-informed policy. These are just a couple of examples of the many ways that we can support health and create opportunities for every Ohioan to thrive. First, by increasing access to green spaces and parks, especially for communities that have historically lacked access. Second is by increasing food access for Ohioans most at risk of food insecurity, especially through programs like Produce Perks. And then finally, by assessing the potential impacts of proposed policies, programs, and services on systematically disadvantaged groups of Ohioans. This can be done using tools like health equity impact assessments. Next slide. The final piece of Becky and I's presentation is to very briefly explain how COVID-19 impacted the data in the 2024 dashboard. We saw it come up in a couple of different ways. First, Ohioans continue to die at a higher rate than other people in other states from COVID-19. This is likely due to many different factors, such as high rates of co-occurring health conditions, a higher poverty rate, and a lower COVID-19 vaccination rate in our state. Next slide. We also saw COVID-19 and the pandemic response affecting other outcomes like education. One example is chronic absenteeism, which is defined as students missing 10% or more of the school year. This increased greatly for all students during and after the pandemic, as many of you are familiar. But now almost 40% of students who are economically disadvantaged are chronically absent from school. So, this is all really complicated, and how this plays out in the data will continue to be seen over time, especially as we begin to unwind those pandemic era policies like continuous Medicaid eligibility and enhanced SNAP benefits. So this is something that we will continue to monitor. Next slide. And I just want to finish our portion of this presentation by saying thank you. We know that many of you are doing the hard work every day, and your leadership on these and other issues is what will drive improvement here in Ohio.
That is so true, Carrie. Looking through the list of people who are participating in today's webinar, There are many familiar names, and I know many people who've devoted their whole career to improving health and well-being in our state. So thank you all for everything that you do on a daily basis for our state. Thank you also to all of you who've engaged in today's webinar so far and put your questions or comments in the chat or Q&A. Keep them coming. Our team will continue to monitor those and answer them as we can. Also, I want to draw your attention to a number of resources that are posted on our website. Not only is the dashboard there and the dashboard snapshot, which is the first 4 pages of the dashboard for those of you who just want something a little quicker to distribute. There is also an FAQ document that includes a lot of great information related to questions we've received over time about the dashboard. And then the full list of metrics is on our website, as well as our methodology. So lots of additional information for you to dig into if that's something that you're inclined to do. While there is much work that remains to be done to achieve health value, many people, again, including those of you who are on today's webinar, are working diligently to improve health value at the state and local levels. As Becky mentioned, the governor's State of the State address yesterday highlighted many actions that are underway or will soon be proposed at the state level. Several of the actions highlighted in the State of the State align with the evidence-informed strategies included in our 2023 or our 2024 Health Value Dashboards or other HPIO publications, including school-based health centers, child care subsidies, and mental health and addiction workforce recruitment and retention. We're now going to highlight some examples of recent local action on policy priorities to improve health value, including efforts related to mental well-being, tobacco prevention, healthcare affordability, and healthy food access. We're going to hear from several panelists, including Julie DeRossi King, who is the CEO and President of the Ohio Association of Community Health Centers, Fran Gerbig, who is the Executive Director of the Prevention Action Alliance, Dr. David Margolius, who is the Director of Public Health at the Cleveland Department of Public Health, and Ms. Julia Lynn Walker, who is the Community Advocates Group Facilitator for Local Matters. I think we're starting with you, Julie, and then we'll hear from the rest of our panelists.
Thank you so much, Amy. It's such an honor to be with you all this morning for a couple of minutes and into the afternoon. And as Amy said, my name is Julie DeRossi King, and I am the CEO and President of the Ohio Association of Community Health Centers. So we support all of Ohio's 59 federally qualified health centers and FQHC lookalikes, and more commonly referred to as community health centers. And health centers in Ohio are providing care to about 1 million Ohioans across roughly 515 sites. And we have a physical presence in 76 of Ohio's 88 counties, although our data certainly shows we serve patients from all 88. And I'm excited to share that for nearly 60 years, health centers have been providing that equitable and integrated whole person care, often providing medical, dental, behavioral health services, as well as pharmacy, vision, and other needed supplemental services all under one roof. The healthcare affordability snapshot on HPIO's Health Value Dashboard shows us, as Becky said, that even though Ohio's uninsured rate has dropped significantly over the past decade, and it's actually lower than most other states, access to affordable care is still out of reach for far too many Ohioans. So in practical terms, what does that mean? Life expectancy in our state and across the country is declining. Chronic disease is the leading cause of death and disability. Our suicide rates have increased 30% over the last 2 decades. Overdose deaths continue to escalate. including a 94% increase among adolescents in recent years. And disparities in health and access persist across racial and ethnic groups, as well as those for living in rural areas. And instead of it getting easier to access primary care, it's actually trending the opposite way. So next slide, please. I wanted to share this snapshot from the Primary Care Collaborative. This is the national pie, if you will, on healthcare spending. And consistent and growing evidence continues to show that primary care oriented systems achieve better health outcomes, more health equity at a lower cost. And yet, despite the strong evidence that primary care is associated with the outcomes that we seek as patients, and important to note, strongly aligns with what our policymakers desire, primary care has chronically been underfunded in our country. And as you can see, on average in the US, we invest about 5 to 7% of total healthcare spend on primary care. Health systems in industrialized nations spend twice that much or more. And I believe the average among the Organization for Economic Cooperation and Development, the OECD, those countries, the average is close to 14%. And in Ohio, according to the Primary Care Collaborative, we're lagging behind the national average, meaning 4 pennies of Ohio's healthcare dollar is spent on primary care. We're just under 4%. And so the sort of good news there, depending how you look at it, because challenges probably on both sides, but the ask or the policy change to seek here really isn't that we need more money, because as a country or a state as a whole, we're spending enough on healthcare and just getting lagging results. And so it's rather a reshuffling of the deck chairs, if you will, and directing more of our healthcare dollar to be focused on prevention and integrated primary care. And so this will shift us towards what we want and what we need more of. And that's that integrated, comprehensive approach to the primary care environment versus specialty care referrals and asking patients to navigate the system on their own. And I can just share personally on a side note that my family, myself, and some of my loved ones, we've had to navigate the healthcare system. And it is so challenging. And I'll speak for me personally, you know, I'm blessed in many ways. I have great health insurance. I have a great village support system. I work in health policy, and I have been just dumbfounded at times at some of the barriers and challenges that I face. And so I often, one of the first things I think about is our community health centers and their patients in under-resourced communities that they're serving, and what it must be like for them, who it's not in the best of circumstances always, if you will. They might be trying to figure out how they're going to make rent, put food on the table, etc. And so that's just really hits me pretty strongly. And every Ohioan really needs to have that primary medical home. It's the quarterback of your healthcare, if you will. And our system just really isn't set up that way. And it really doesn't invest in primary care and prevention like we could or should. And so this is exactly what we need to do to create. We need to create more essential and that appropriate capacity. And if we do, that's going to drive down that emergency department and urgent care utilization for those non-emergency and non-urgent needs. I did want to just spend a quick minute talking about Medicaid specifically, you know, covering nearly 90 million people in our country. In Ohio, I believe it's around 3.15 million that are covered by Medicaid. And so the vast reach of Medicaid and the CHIP programs make them a key vehicle for bettering the health of underserved and under-resourced communities. And despite its importance, the per person spending on primary care in Medicaid is lower than what we typically see in commercial insurance. And it's actually declined almost every year since 2014. And certainly low Medicaid payment rates create barriers to care for patients when traditional practices are forced to limit their Medicaid patient panels, which is restricting our capacity. So unsurprisingly then, Medicaid enrollees are also disproportionately, again, relying on emergency departments as their usual source of care, where care is focused on treating that acute system that brings you to the ED rather than that more global focus on prevention, chronic disease management, and maybe, and certainly equally as important, but that ongoing relationship between the patient and that quarterback, and just their care teams. So next slide. This is also an infographic from the Primary Care Collaborative that lists in no priority order strategies and policies to strengthen primary care in our Medicaid programs. And I know I'm running into my time, but I did want to lift up increasing the payment to primary care providers. And so the US as a whole, I don't think this is news to anybody, but we face a really serious shortage of primary care providers and physicians for many reasons, but one in particular is really indisputable, and that's compensation. And so on average, a primary care physician can earn roughly, let's say, $250,000 a year, and their specialty counterparts can expect to double or triple that. And so when you think about the pay disparity and also the punishing workload typically faced by primary care providers, our doctors that are finishing school and our providers that are graduating, they are incentivized to move into specialty care, which leaves us as the patient with fewer choices to access primary care in the most appropriate and adequate setting. Like Becky said, doing that not only is costly, but you're not building that rapport, and the ED just isn't where you're going to get the best global approach to prevention and chronic disease management. So a pathway to correcting that disparity is also addressing the payment for primary care providers, which is notably also very low relative to their peers. So I'll leave you with that, and just thank you to HPIO and also the esteemed panel. It's an honor to be here with you all now this afternoon.
Thanks, Julie. Next, we'll go to Fran.
Good morning. Thank you for inviting me and allowing me to share some thoughts. To those folks on the webinar who are not familiar with Prevention Action Alliance, we are a statewide certified prevention agency located in Columbus, Ohio. We provide professional development, mini grants, training and technical assistance to coalitions and prevention professionals across the state of Ohio who are doing the important work, trying to get ahead of the mental health and addiction crisis that is impacting our state. So really, I am blessed to be able to work with such leaders and with such passionate folk here in the state. You know, some of my thoughts as I was reviewing the health value dashboard, kind of a silver lining of the COVID-19 pandemic was the reduction of stigma that surrounded mental health. We all acknowledged and felt the anxiety and depression during that time. We encouraged our families and friends to find support, and we personally were motivated to seek help and work to develop strategies to support and enhance our mental health. And that was a really huge step forward. But it's very disheartening to see now the increased rates of Ohio adults post-pandemic who are reporting depression, as well the growing numbers of Ohio youth who feel hopeless. A policy priority must be to address and prevent these growing numbers, and that's going to take a multifaceted approach. First, an essential priority should be the full implementation and evaluation of the Ohio Suicide Prevention Plan. Policies with adequate funding to fully implement the plan, as well as to maintain and improve the 988 helpline and expand crisis services, are paramount. It's necessary. We need to meet people where they are, provide culturally appropriate responses, and if necessary, and I'm going to harken back to what Julie just referenced, make sure that there is a caring individual to help them navigate that behavioral health system. It is very, very challenging. And when you're in crisis, that's not an additional stress that anyone needs. Policies that support the further development of the behavioral health workforce are also going to need to be prioritized. With the legalization of cannabis and the ongoing addiction epidemic in Ohio, more and more Ohioans are going to be negatively impacted by mental illness. In a recent Kent State University survey, Ohio youth and young adults reported using marijuana and alcohol to cope with mental health related issues, such as anxiety, depression, or stress. There's concern that youth and young adult self-medication practices will only compound the mental health risks that exist for them. The depression and mental illness and substance use disorders that will develop as a result of this self-medication will necessitate an expanded behavioral health workforce. Policies that uphold the development and financial support of a trained workforce to meet crisis needs, as well as to support health and long-term wellness, are going to be vital. It is essential that behavioral health services be available to all Ohioans through a variety of modalities to best meet the needs of the individual. However, if we do not work upstream to determine root causes of this mental health crisis, we will be chasing our tails. Priority should be placed on the development of policies and sustainable funding to support the expansion of prevention services across the state of Ohio and build the necessary prevention workforce to meet the needs of all Ohioans, from young children to older adults. We need to be working upstream to mitigate the causes of depression and anxiety and other mental illnesses. Prevention professionals can circumvent risk factors and build protective factors. They can implement strategies to build resiliency, to reduce stigma, as well as limit experimentation and other risky behaviors. With an expanded and specialized prevention workforce, we can identify emerging problems early and refer at-risk Ohioans for the care and intervention that they need. However, prevention education and early identification and referral to services, that's only one part of a comprehensive strategic prevention plan. To fully protect Ohioans, it's time that we empower communities with the resources, knowledge, and skills necessary to identify prevention strategies that are meaningful to the community, to best identify and prevent mental health challenges. We need to create conditions for communities to flourish. We need to provide resources and education that help communities to help themselves. Let's capitalize upon prevention science and find local solutions for local concerns. A policy priority should be to create a sustainable system for behavioral health coalition development and funding. And finally, we need to acknowledge the impact that screen time and cell phone use has had on the mental health wellness of Ohio's youth. The fact that 43% of Ohio high school students report feeling consistently sad, hopeless, and alone is unacceptable. This winter, Prevention Action Alliance had a very unique opportunity to work with a group of high school students who are concerned about the impact of cell phone use among their peers, and they were empowered to advocate for change. 27 Minutes is an educational campaign created by 3 students at Olentangy High School here in Central Ohio. The name of the campaign, 27 Minutes, is derived from the amount of time it took a classmate who was targeted on social media by a predator to slip into despair. After images were sent to whom he believed to be a teenage girl, the interaction quickly turned into extortion. The messages continued back and forth for 27 minutes and resulted in this young man feeling so helpless that he took his own life. 27 Minutes focuses on educating parents and other caring adults about the dangers and issues of social media. Prevention Action Alliance published a series of special edition no tips that discuss topics related to sextortion, depression, anxiety and self-esteem, personal safety, addiction to social media, and Ohio's Social Media Parental Notification Act. These tips were written by teens. These words came from teens so that caring adults everywhere could understand the scope of the problem. To say that these students were disappointed by the injunction that prevented the act from becoming law would be an understatement. So why design to educate adults and spotlight the risks facing children and youth? These tips, this campaign, 27 Minutes, serves as a call to action to all of us to prioritize youth mental health wellness. We need to listen to these students and create a safe environment for them and for their peers to grow and experience the world. We need to listen to their recommendations and put limits around child and youth use of cell phones. We need to help them build relationships that will encourage them to see the future. We cannot wait for the federal government and do so. Ohio needs to prioritize policies now that support parental controls and limit child and youth use of cell phones. Thank you, Amy, for this opportunity.
Well, thank you, Fran. I wasn't aware of that initiative, so thank you for bringing that to our attention today. And next, we'll hear from Dr. Margolius.
Thank you, Amy, and yeah, thank you to the HPIO team for inviting me. I'm honored, and thanks to all 226 participants. That's pretty cool. So I am going to briefly touch on the statewide tobacco control policy landscape, and the headline is essentially due to recent actions. There are lots of opportunities to make a difference in this space. And so if you're looking to save lives and prevent disease and disability, working on tobacco policy is for you. So Ohio's smoking rate is 17% of adults smoke a cigarette in the last 30 days, which is the 5th highest in the nation. In Cleveland, where I serve, I'm the director of public health. Our smoking rate is 35% of adults. That is one of the highest, if not the highest in the country. The rest of the country, the national average is 11%. That's down from 20% about 20 years ago. And at the same time, Cleveland's smoking rate has gone from 30% to 35%. Why is this important? Well, as I alluded to earlier, smoking is the number one preventable cause of death, disease, and disability. In Ohio alone, in 1 year, 20,000 people, more than 20,000 people die of smoking-related illnesses, and smoking kills more people than alcohol, car crashes, drug overdoses, homicides, and suicides combined. At its peak, COVID caused death of 500,000 individuals back in 2020, and cigarettes take the lives of 480,000 people in our country every single year. So this is a huge problem, and everybody on the call has lost a loved one or someone that they're related to due to smoking-related illnesses. So why is Ohio's smoking rate so high? Why is Cleveland's smoking rate so high? One main reason in Ohio is our state taxes for packs per cigarette are much lower than our neighbors. So our state tax for a pack of cigarettes right now is $1.60. In the state of New York, tax on one pack of cigarettes is $5.35. And the state of Pennsylvania, it's $2.60. And so we're essentially getting what we pay for. There was this great article in the Washington Post that compared the corner of Ohio with the corner of Pennsylvania and the corner of New York, showing that after those different taxes were implemented, life expectancy for New York improved, life expectancy for Pennsylvania improved, but not as much. Smoking rates in those states improved in the same pattern, but Ohio's got worse. And so that's a big part of this, and I'll go into a little bit more about the policy of why else. Now, in Cleveland, why is our smoking rate so high? So number one reason is that we're a city in Ohio. But number two is that in 1970, when it became illegal to advertise smoking on television and then radio, smoking rates started to decline across the country, and Big Tobacco sat in a room with their marketing agency. This is all documented. All the documents are available, and basically said, we've got to find new customers. And their conclusion was the new customers would be people who are poor. They were going to link smoking to being in poverty. They said, we're going to go after youth. So start with those flavored products. And then we're going to go after Black smokers and other oppressed demographics to kind of link smoking with those demographics. And so back then, of Black smokers, just 5% smoked menthol cigarettes due to a really targeted evil campaign. Now it's nearly 90% of people who are Black who smoke menthol cigarettes. And so in Cleveland, our rate got up to where it is today, about 35%. So what policy does exist in Ohio? Not much. I would be remiss in not giving a great shout out to 1-800-QUIT-NOW, which the Ohio Department of Health runs. It's a free hotline for anybody who is trying to quit smoking or just wants to talk to a coach on different strategies for quitting smoking. That exists. But the rest of the state, a number of smaller jurisdictions like Columbus and Cincinnati and suburbs throughout Cuyahoga County had a tobacco retail license system, but due to the actions of the Ohio legislature, they just passed preemption by overriding Governor DeWine's veto. And so any local policy that's stricter than the state policy is now illegal. And so all the flavor regulations that were going to go into place, all of those tobacco retail licenses that paid for enforcement of Tobacco 21 rules, all of those are now off the books. And the only remaining regulation is every once in a while, the Ohio State Patrol will go into a tobacco retailer and try and see if they're following the right procedures to ID people who look like they're under 21. So what could exist? Well, number one, we got to raise that statewide tax. I mean, it's embarrassing that we've got one of the lowest taxes for packs of cigarettes in the country, and we get what we're paying for. Number two is, sure, a patchwork system of tobacco retail licenses, maybe that wasn't the best approach, but it was something better than nothing. But if Ohio legislatures, policymakers are interested in a statewide tobacco retail license policy, that would be incredible to do the same thing that our local health departments do today with restaurants and other retail food establishments, where they, hire us, the local health departments, to go in and do health inspections to make sure that they're doing the right things. And then lastly, it would be wonderful to do some kind of flavor regulation, because flavors are really developed by big tobacco to recruit new smokers and not help current smokers quit. So joining the dozens of countries that already do this, joining the 2 states and the 400 jurisdictions that already do flavor regulation would be wonderful. And my last point as I come off here is that Cleveland joined Columbus and I think a total of 14 jurisdictions to file a lawsuit against the state of Ohio, so that we can try and overturn this preemption law that was passed. And so our goal is, essentially saving lives. We're not giving up. We hope this lawsuit is successful, but in the meantime, if the state is able to pass a statewide tobacco control measure, that would go a long way to helping people in our state. Thank you.
Great. Thank you, Dr. Margolius. And we've already mentioned this. However, just want to emphasize that adult smoking rates are highly correlated with health value. So here in our state, we do have a relatively high adult smoking rate, and we also have poor health value. This is one of the things that we could take action on and likely see improvement in both population health and, population health equity and in healthcare spending. Our final panelist of the day is Ms. Walker with Local Matters.
Thank you very much. And there's so much I heard before from the previous panelists, but I'm going to stick to the script and stick to time. So thank you very much for the invitation to present on food access. Yes, I coordinate the community advocates at Local Matters, which is a group representative of a variety of community interests that identifies gaps in food access and seeks to provide proposals for remediation. The community advocates are currently concluding a project on food access as a part of emergency management planning. Local Matters overall focuses on food education, access, and advocacy. Finally, I am also a member of the OSU Wexner Medical Center Health Equity Advisory Board. Coming to this presentation, when I reviewed the HPIO dashboard, I was appropriately horrified at a number of statistics, many of which you've heard already. What I'd like to bring to your attention today as an area for policy change is Ohio's ranking as the 50th state for nutrition education. 50th because it is the only state in the United States that does not have health education standards, and therefore a rather ad hoc, random patchwork process exists with respect to how children learn about what is good for their bodies. Yet we expect them to thrive intellectually as well as physically throughout 12 years of state-provided education. Yet Ohio is facing, as we've heard today, so many, really an unprecedented number of health challenges due to an increase in diet-related chronic diseases. And yes, economic stability and even national security are negatively impacted by rising rates of conditions like diabetes, hypertension, heart disease, and even some cancers. So as we've heard, or you will see as you review the dashboard even more, with respect to population health, Ohio is 41st in adult depression, heart disease mortality, and adult diabetes, 39th in premature death, and 38th in life expectancy. While I appreciate the areas indicated under creating opportunities to thrive in the dashboard, as we heard this morning, specifically increased food access for Ohioans most at risk of food insecurity through initiatives such as the Special Supplemental Nutrition Program for Women, Infants, and Children, more popularly known as WIC, and the Senior Farmers Market Nutrition Program, I would also urge us to focus on the development of a nutrition education framework. What could be the value of such a consistent nutrition education framework for the Ohio public school systems? How could such a framework turn the statistics that we've heard this morning around? A comprehensive food education framework can help students to build an understanding, one, of food's role, not only in the American culture, but in many cultures, our relationships within our communities, our individual histories, and even our environment. And again, we heard this morning how 50% of the physical economic environment really impacts the healthcare criteria. This knowledge can empower our children to make healthy choices and achieve success both inside the classroom and beyond. A comprehensive food education process deepens our commitment to uplifting the health and well-being, not only of our students, but also of their families. With such a process, what objectives could we identify? One, we would help students to build knowledge about lifelong healthy eating and wellness overall. We will provide greater access to healthy, nutritious, and culturally appropriate meals in schools. And three, we could empower members of school communities, and that's the entire community, including parents, educators, food service workers, and administrators, in addition to the students, to be wellness ambassadors. Building healthy eating habits early is essential. It's essential for our students' development and for making them better learners. Building healthy eating habits brings us closer to the day when all of our young people are connected to experiences with food and nature while addressing climate change, individual health, and social equity. Building healthy eating habits with specific goals, strategies, and key performance indicators will ensure that students across the state learn healthy eating habits and how each component of our food system overall interacts with the climate, economy, and individual local communities. In the meantime, we acknowledge and support the statement by the Columbus Public Health Department that racism is a public health crisis in the city of Columbus and certainly beyond. And we recommit to all efforts to ensure that we understand the disparate impact of what can often be perceived as neutral criteria. We propose that we focus more systematically on the implementation of the local food action plan and even the Columbus Action Plan for disparate impact, as well as identifiable areas of value that could contribute to a future state of Ohio nutrition education framework. With that, I will conclude and say thank you very much. I look forward to your questions and comments.
Thank you, Ms. Walker. You did a wonderful job of connecting the idea of how individual actions and our own behaviors and choices are influenced by the environments in which we live and the opportunities that we have available to us. So thank you for doing that. All right, so our panelists will be with us throughout the rest of the webinar. Feel free to pose any questions that you have for them in the Q&A or chat. And now we're going to introduce Dr. Lynn Silver, who is the principal investigator at Getting It Right from the Start. As cannabis use is one of the key themes in the 2024 dashboard, Dr. Silver is going to deepen our understanding of how to develop a thoughtful policy framework for cannabis regulation that balances public health, public safety, and equity consideration. Good afternoon, Dr. Silver.
I'm
Good
sorry to
afternoon.
interrupt. Amy, can we do our poll questions really quickly, please?
Oh, sure. Sorry, Dr. Silver. We
problem.
need to do our poll questions. Okay. So please take a moment, all of you. We very much appreciate you being with us today. We ask for your feedback so that we can assess whether or not our webinars have met our objectives. So if you could just take a couple of seconds here to respond to these questions. And remember to scroll down. There are a total of 5 questions for you to respond to. And while folks are finishing up responding to those questions, I'm going to go ahead and ask you, Dr. Silver, just to begin your remarks, and then we'll catch up in a second with your slides.
Okay. First of all, it's a pleasure to be back with folks from Ohio. I have been involved a little bit over the past few months as issue 2 came up on the ballot, and learned to know and love a few of you. But I want to just open by commenting that so much of what I was just hearing from the previous speakers really interweaves with the cannabis issue. The increasing burden of mental health challenges in the state is both, we're both seeing people both trying to treat that burden with cannabis, in part because of the barriers in access to care that Julie DeRossi and others described, the high copays, the difficulties in access to mental health professionals, the issues we're seeing in schools with absenteeism, and other problems are being exacerbated by increasing problem use of cannabis by youth, and the patterns of behavior of major commercial players like the tobacco industry are being, that Dr. Margolius described, are being duplicated by the cannabis industry in the state of Ohio and need to be addressed. So many of these issues are interwoven and overlapping in many very important ways. Next slide, please, Jasmine. So this is stolen from the alcohol discussion, but like alcohol, cannabis is no ordinary commodity. We cannot treat it as any other sector of the economy whose sale we want to maximize and vitalize and think of as a positive area for economic growth. And yet in many cases, that's the way it's being treated. So even though cannabis does have some positive medical uses, and we're increasingly learning about those, it also has many serious problems that I'll try and address briefly. Next, please. Just looking at what's happening across the country over the past 30 years or so, we saw a decline in the 1990s, but then use has since rebounded, and that is highest of all groups in our young adults, people aged 19 to 30, with about a 42% rate of past use in the last 12 months, although Ohio's not the highest state in the nation on that. Next, please. Really, what gets most worrisome is daily use, when people are using frequently, daily or near daily, And as in alcohol, those folks are the folks who are responsible for perhaps 80% of the sales and consumption. The folks who are more problem users, the rate of daily use in young adults has tripled over the past 30 years or so. And we now see almost 11% of young adults using cannabis daily or near daily. So that's, 1 out of 10 young adults in America walking around stoned almost every day. And that is a very worrisome trend. Next, please. So cannabis harms, I know Ohio has had a very severe opioid epidemic. Cannabis harms are typically not as severe or dramatic as fentanyl or opioid overdoses, but their harms are varied and quite serious, and they have been exacerbated by the massive transformations in the market to very high levels of THC content, so that the products being sold today bear very little resemblance to the traditional botanical. They are industrialized, very high potency products. And because the base of use is so widespread, much higher, more like tobacco and less like opioid use, the population health impacts can be quite significant. And some of these include really irreversible harms to children who've been exposed in utero, and increases in psychosis, to me, are the two that are most worrisome in terms of their long-term harms and difficulty reversing the effects in many cases. Cannabis does not typically kill people like fentanyl, but it does do so indirectly by causing acute psychosis, increasing suicide risks, and car accidents. So I think one of the things that we're trying to fight is the perception of cannabis as a healthy natural wellness product, which is how it's being marketed by the industry. Next, please. So some of the evidence-based harms that we know are associated with cannabis are low birth weight when used during pregnancy, increases in schizophrenia and psychosis, as well as suicidality, increased motor vehicle crashes, respiratory illness, and cannabis use disorder or problem use, which is particularly likely to occur when people start using young and use frequently. Next, please. We are seeing also a significant growing literature on cognitive, academic, and social effects, growth in dependency, accidental ingestions and overdose, and most very significantly, cardiovascular disease. What we don't see, unlike tobacco, for example, is lung cancer. Next, please. Some of the emerging trends that we're seeing nationally is a 3,300% increase in pediatric cannabis poisonings, a near doubling of use during pregnancy, despite the data showing harm, very large increases in emergency room visits associated with cannabis, many for psychosis, anxiety reactions, and other problems, and a very, very large increase in older adults coming to the ER with cannabis-related problems. Next, please. In children in particular, in California, we studied 360,000 women, and we saw increases in low birth weight, small for gestational age babies, preterm birth, and NICU admissions in women who are using cannabis while controlling for other factors. For me, I find this particularly worrisome for its potential to exacerbate existing disparities in neonatal outcomes. And I think this is something we need to be very attentive to. Next, please. So issue 2 appears to have been written by the cannabis industry. The good news is, unlike some other states where ballot initiatives can't be modified by the legislature, the Ohio legislature does have the ability even to fully repeal, but also to extensively modify it. So some of the problems with that ballot initiative can be fixed if there is political will to do so. Next, please. So as your state is undergoing this legalization process, I just want to raise some issues for you to think about. Next, please. First, that there is no free ride. We see a perception that cannabis is a wonderful new sector of economic development and that we will get lots of tax revenue from it. But in reality, that comes at a very high price. Policies that drive up cannabis use will drive up harms. And by adopting more cautious policies that may allow legal access but do not promote cannabis use, the burden of these negative health impacts can be not actually avoided, but reduced. Next, please. Just to give one example, I'm going to focus on psychosis and schizophrenia. The actual estimates vary across countries. Denmark estimated about 8% of their new psychosis cases were due to cannabis use disorder, 20% of schizophrenia in young males. Other studies from multiple cities in Europe found an average of 12% of new psychosis cases associated with high potency cannabis. And daily use of high potency cannabis was increasing risk of psychosis about 5-fold. In Amsterdam, it was estimated that as much as 50% of new psychosis cases may be cannabis associated. Next, please. So these numbers are a little bit, uncertain, but the bottom line is some part of psychosis and schizophrenia is increasingly triggered by cannabis. It's associated with genetic risk, but it's much of it is being triggered often in people who might not have otherwise developed the disease by consumption of cannabis, and particularly the high potency products. In every case of schizophrenia, costs are in the United States about $90,000 per year lived with schizophrenia, with a societal lifetime cost per person of over $2 million. So if we develop our cannabis policies in ways that will increase this risk, which is exactly what we're doing in most of the United States, we are also going to be increasing our spending, not to mention the terrible suffering associated with severe mental illness from these conditions. Next, please. We don't have perfect cost-benefit analyses yet of how the benefits of legalization and harms are playing out, but we do have enough data on harms to know that we can reap criminal justice benefits, but we do need to invest in containing the harms so that the net effects of legalization are hopefully more positive than negative. But it's very challenging. Next, please. To do that, we need to consistently adopt policies for the new legal markets that will prevent cannabis-induced harms. And that's not what's happening in most places. Next, please. When we think about the equity aspects, we mostly hear about the issues on the left. So the criminal justice reforms, which are absolutely critical, and the potential economic benefits to the communities harmed by the war on drugs from licensing, which have been to a significant extent overrated in how effective that's been. But we also need to think about how tax revenues are used and how that will affect health and social equity. And we need to think about the impacts of increasing cannabis consumption on pre-existing health disparities and other areas of health equity. I think only by looking at these 4 spaces of analysis of equity can we really understand and address the equity implications of legalization. Next, please. Ohio in 2018 ranked 28th in the nation for the largest racial disparities in marijuana possession arrests. Black people were 3.4 times more likely than whites to be arrested. That has generally, these trends have typically persisted after legalization, but the absolute numbers have gone down. I don't have more recent data for Ohio, however. Next, please. In truth, we have seen tremendous benefits post-legalization. In arrest rates in California, we saw a 98% decline in possession arrests, and we saw 87% of criminal records successfully expunged, which can have very positive influence on people's lives. But I would note that you don't need to legalize for-profit commerce to obtain these benefits. These criminal justice benefits can be obtained separate from creating a for-profit industry. Next, please. When we look at issue 2, it legalizes possession, which had already been partially decriminalized, but it still has steep penalties for minors. And it said nothing about expunging criminal records. I understand that's under discussion, but that was not in the issue. So we strongly recommend including and funding automatic expungement of criminal records and reducing underage penalties as part of subsequent legislation or regulation. Next, please. When we look at issue 2 and you say, well, what was its purpose? Its stated purposes were to reduce the illicit market and provide a safer legal product, to limit the influx of out-of-state cannabis, and to fund social equity and job creation. But it said absolutely nothing about protecting kids or public health or not increasing consumption or reducing criminal injustice. So I think one thing that's very critical is just in the subsequent legislative and regulatory process to create a clear intent and primacy of protecting youth and public health and not driving up consumption through the process of legalization. That is not currently the case, although I may not be totally up to date on your legislative follow-up. Next, please. Who is in charge? In issue 2, it's the Department of Commerce, which will typically view it as an economic growth rather than as a public health issue. And we believe it's very important to have an active public health role in these key decisions about this new legal but harmful product. Next, please. The market structure creates a for-profit market with very few limits. We recommend safer alternatives like alcohol monopolies or nonprofits, which is the model adopted by Quebec, but that is not the current proposal in Ohio. Next, please. We also recommend very strongly limiting the number of retailers to no more than 1 per 20,000 people, limiting the amount of cultivation so that excesses don't drive up illicit market and push down prices further, buffers from schools and other youth serving locations, and strengthening equity and licensing. Next, please. Just to give an idea of what happens when you allow too many retailers, this is our data from California on prenatal use, and it's, a dose response relationship with how many retailers are within a 15-minute drive from a woman's home. We saw the same thing with adolescent consumption. Next, please. Issue 2 basically did what Dr. Margolius was just describing on tobacco, which is it preempted much local control. Municipalities can prohibit or limit operations, but that can be overridden by a ballot initiative. Local cannabis taxes were not allowed, and many other actions were restricted. We recommend stronger local control, including taxation and non-preemption. Next, please. The taxes that were established for Ohio were very low, a single 10% excise tax, which is much lower than many other states, which were 20 to 40%. And it does not tax by THC content, which is probably the best practice. And it does not prohibit discounting of tobacco products, of cannabis products. So we recommend higher taxes tiered to THC content dedicated to youth and prevention and equity, and prohibiting discounting of cannabis products. Next, please. Does issue 2 make the product safer? No, in reality, it protected the most dangerous products. It guaranteed the ability to continue to sell the very highest potency products, which are those that place people at highest risk of addiction and psychosis, and explicitly protected 26 classes of products. So we strongly recommend limiting potency now. You can always change that later, requiring plain packaging as 4 states do in Canada, and requiring prominent graphic rotating warnings on products. These are the Canadian warnings. Next, please. Does issue 2 prohibit the cannabis kids menu? It does not. It allows beverages. It prohibits pre-approval. We recommend not allowing flavored inhaled products, as Dr. Margolis was discussing for tobacco, not allowing canna pops, flavored pre-rolls, and clearly defining and prohibiting products attractive to children and setting up a pre-approval process for that, which would need to be modified from the ballot initiative. Next, please. These are just examples of some of the crazy kid attractive products that look like typical foods that are being sold in California. Next, please. And these are similar hemp products. Next, please. Issue 2 did not protect smoke-free air well. It did not prohibit on-site consumption lounges or cannabis temporary events. We strongly recommend strengthening those provisions. Next, please. It also did not restrict advertising, and in reality, it made it harder for the new division to do so. We strongly recommend prohibiting billboards, having stronger targeting requirements, prohibiting therapeutic and health claims, and clearly defining what advertising that's attractive to kids is. Next, please. So to wrap up, Ohioans, you are entering the world of legalized cannabis. Next, please. For the next years, you are going to see a prize fight. Both the legislative and regulatory frameworks are being defined. In most states, this has been characterized by industry dominance of the discussion and rapid regulatory capture, where the regulatory agencies are serving more the interest of the industry than the public interest. It is very, very critical that public health, substance abuse, tobacco leaders become engaged in this process now, because you can expect a very strong and very active cannabis lobby trying to do all the things that Dr. Margolis described going on in the tobacco industry. Next, please. Fight, you can make this better and have better outcomes if you fight now and in the coming years to change the legislative and regulatory framework to accomplish some of those recommendations I just mentioned. I won't repeat them because I know my time's ending, but limit potency, limit products attractive to kids, flavors, tax high THC, and so on, and limit the number of retailers. Next, please. And this is a limited window of opportunity. I mean, the fight will go on for 50 years, but the next year or two is a particularly important window of opportunity. You need to come to the table, show up, speak out, bring your youth, bring your school principals, your nurses, your parents and educators, because otherwise you will get a system that will be very harmful for many years to come if it continues as was written in the ballot initiative. Next, please. So thank you for the opportunity to join you. Please visit our website, Getting It Right from the Start, or join our listserv. We try to support community partners and government partners around the country as much as possible. Thank you.
Thank you very much, Dr. Silver. And you've not missed anything on the legislative process here in Ohio. It's at a standstill right now. And your presentation is very timely. It's also somewhat anxiety producing because there's a lot of work to be done as we move forward with this new state of affairs on cannabis. So thank you so much for offering up all of those ideas.
Thank you. Don't mean to make you all anxious, but I kind of do.
I'm speaking for myself, and
but productively, not just contributing to the mental health trauma.
Yes. Right. Well, thank you for joining us today.
Good luck.
We're going to end our webinar by exploring another topic, which is the relationship between voter participation and health. And we're going to provide you with some resources on this topic as well. In 2023, an organization called Healthy Democracy, Healthy People produced a Health and Democracy Index. The index compares states on accessibility of voting and on health outcomes, finding that states with less voting access tend to have worse health outcomes. Ohio is an example of such a state. A causal link between voting access and health has not been established, but there does appear to be a strong relationship between the two. Also in 2023, Healthy People, the federal body that establishes 10-year measurable health objectives and targets, recategorized its voting rate objective from being a research objective to being a core objective. Given this growing body of research finding a relationship between civic engagement and health, we decided to add 2 new metrics to our health value dashboard, and that is voter registration and voting ranks. And I'm having some trouble controlling my slides. So Jasmine, could you just go ahead and control them for me? I'll say next slide. All right, we're on the right one right now. The most recently available data is from 2020, and Ohio performed relatively well. A year ago, a new law went into effect here in our state that put in place more requirements related to voter IDs, voting by mail, and early voting. It'll be important to track these new dashboard metrics over time to assess any impact of this recently passed legislation on our voting rate. There are many opportunities for us all to take action to increase awareness of the importance of voting. Many of you, next slide please, Jasmine, and next slide. Many of you participating in today's webinar work in health-related organizations. You may be surprised to learn, like I was, of a recent study that found that healthcare workers, including physicians, nurses, physician assistants, and dentists, are 12 to 23% less likely to vote than the general population. Next slide. 3 national organizations are partnering on an initiative called We Will Vote that aims to strengthen civic and voter participation across the health sector. Both organizations and individuals can become champions of We Will Vote. You can get more information at the website on this slide. Next slide. Another way to promote voting is to educate yourself and others about how, where, and when you can vote through websites such as voteohio.gov. As these new ID requirements go into effect, this is particularly relevant to know what kind of ID is needed for voting and to make others you know, including people you serve, aware of what IDs are required to vote now. Another website to go to for more information is Vote 411. Next slide, Jasmine. This also provides a lot of resources related to voting here in our state. And next slide. Last, the County Health Rankings and Roadmaps is sponsoring a webinar next week that'll explore strategies to strengthen civic participation for communities' health. So we would encourage you to sign up for that webinar as well for more information. Our final words, next slide, please, are focused on other ways that you can influence policy. Of course, voting is an important first step. As my mom always has said to me, you can't complain if you don't vote. And I like to complain, so I vote. There's many other ways that you can influence policy. You can write letters, make phone calls to your elected officials. You can testify in legislative committees. You can participate in other groups that share the same interests that you are and that are working together collaboratively to impact policy change. We're here at HPIO, we're very focused on data and evidence, and we encourage you to use the resources we have available to educate yourself and others around health issues and around policy changes that can improve health. One of the things I wanted to mention too before we leave today is we have what we call facts and figures available on our website. And if you go to that section, you're able to download slides with the graphics that we produce on our publications. So please feel free to do that if you would like to use our slides to inform others. I think we have one more set of poll questions for you all to respond to. So Jasmine, could you please throw the poll? Thank you again to all of our presenters today and our panelists. A final reminder that all of the materials from our webinar are posted on our website, as well as the dashboard itself and other related resources. The slides from today are also posted online, so you can download all of those there. There's several questions again, so please scroll down. Let's see, we have 9 questions here as we close out our session today. We do value your feedback. We utilize that feedback to plan future events. It was wonderful to see you all here today, and thanks in particular for the very robust conversation that's gone on in the Q&A and the chat. We hope we've provided you all with the data and the analysis that you need, and we look forward to continuing to work with you. Thank you again for everything that you do to improve health and well-being in our state. And with that, I think we'll close the poll here in a second and wish you all a great rest of the day.